Hello, my name is Rosalina Perez, and this is my collaboration and leadership reflection video for NURS FPX-4010, Leading People, Processes, and Organization in Interprofessional Practice. In this video, I will be discussing my personal experience of interdisciplinary collaboration. I will go into depth of how this communication was successful, unsuccessful, and if the desired outcome was achieved. I will also be discussing these topics. I will identify ways poor collaboration can result in inefficient management of human and financial resources. I will identify best practice leadership strategies that would improve an interdisciplinary team's ability to achieve its goals. I will identify best practice interdisciplinary collaboration strategies to help a team achieve its goals and work together more effectively. I will also be referencing 3 evidence-based articles in my reflection. Before we begin, I want to give you a brief description of my nursing background. I graduated in 2009 for my associates in nursing. After graduating, I was offered a new grad position in a small community hospital in their labor and delivery unit. Since then, I have continued to work in labor and delivery, but now in a military facility. For my personal experience in interdisciplinary collaboration, I'd like to share a story of how my hospital managed department-wide staffing shortages. As a result of COVID-19 pandemic, healthcare organizations across the nation have been overwhelmed and understaffed. Many hospitals, including my own, devised structural modifications hospital-wide to address staffing shortages. My labor and delivery unit consists of 6 triage beds, 12 labor/antepartum beds, 2 pre-op and post-op recovery rooms, and 4 OR suites. Prior to the peak of COVID, our L&D triage functioned similarly to that of any other hospital. We triaged all patients greater than 20 weeks with any OB concerns or issues, and patients referred from the clinic. On a normal triage day, we may see anywhere between 10 to 15 patients within 24 hours. Our triage was normally staffed with 1 nurse and a military corpsman. Over the course of a year, we started getting details on various categories of patients that would present themselves for triage. At first, the IV infusion clinic started operating during limited hours. Leadership decided that we would accept all pregnant patients who are needing IV infusion therapy. Then we were informed that a significant number of our obstetricians were either retiring or being deployed, leaving our clinics understaffed. Because of this, the chief physician and OB department communicated to our leadership that they would be sending a significantly greater number of patients to triage, especially on weekends. On the list were complicated postpartum patients needing either their 2-day or 2-week follow-up. In addition, they were also sending early gestation patients needing to complete a missed or spontaneous incomplete abortion. The final straw was when we learned that the emergency department would now be sending any potential pregnant patients with early trimester concerns to triage. Most of the time, we saw patients with missed periods and not pregnancies. It was becoming increasingly difficult to properly triage patients. Floor staff was being pulled into triage to accommodate the large influx of early trimester and postpartum patients. Sometimes even our scheduled appointments like inductions, cerclages, and even cesareans were postponed due to the overflow of triage and the potential admissions that may follow. Theoretically, utilizing our triage to accommodate patients who would have otherwise been seen elsewhere seemed like a good idea to aid in clinic shortages. However, this required our nursing personnel to perform jobs which we were unfamiliar. In addition, it raised the unit's stress load, at times causing nurse burnout. It should be stressed that professional burnout is a negative factor that affected the safety and quality of patient care. In this case, the poor collaboration of our leadership with other departments and clinics caused inefficient management of human and financial resources. Referencing a study published in 2019 titled "The Relationship Between Burnout, Job Satisfaction, and the Rationing of Nursing Care, a Cross-Sectional Study," this article discusses the term of rationing of nursing care, which is defined as missed care in nursing that manifests in the withholding and failing to carry out necessary and essential nursing tasks because of time limitation, staffing levels, and skills mix. This literature highlights factors such as understaffing, burnout, and stress exposure, when nurses are likely to be forced to select or skip specific tasks, thereby increasing the risk of adverse outcomes of patient treatment. Increased mortality, hospital falls, poor quality care, bed sores, and nosocomial infections are some of the negative outcomes when rationing of nursing care. Unfortunately, this is not the first time our unit has had to deal with shifts in unit policy. Working in both state and federal hospital settings has given me a unique insight on how their utilization of people and financial resources differ substantially. A huge difference is that many of the leadership positions within the federal hospital are held by high-ranking active duty officers. Consequently, many of these active duty members receive orders to relocate every 3 years or sometimes less. Therefore, when our leadership changes, our policies change. When our leadership changes, I always hope that they bring a sense of humility when working in a new environment. Which now leads me to identify best practice leadership strategies that would improve an interdisciplinary team's ability to achieve its goals. Interdisciplinary collaboration demands not only professional competence, but also positive personal attributes. In an article published in 2019 titled Concept Map of Dispositional Humility Among Professionals in an Interdisciplinary Healthcare Environment Qualitative Synthesis, this literature states that dispositional humility allows clinicians to have an accurate self-assessment, to be open to new ideas, to appreciate the contribution of others, and develop generosity. Dispositional humility in leaders can facilitate character development of team members and create an environment characterized by fairness and equality, transparency, non-punitive consequences for reporting errors and near misses, and a safe and encouraging environment. Leaders whose success is based on their ego will inevitably fail because they lack the strategic humility necessary to succeed. And finally, I will identify best practice interdisciplinary collaboration strategy to help a team achieve its goals and work together more effectively. Teamwork and communication are of the utmost importance in labor and delivery, since they are the foundations for better satisfaction, patient satisfaction, staff satisfaction, patient safety, and decrease of clinical errors. In an article published in 2018 titled Changing Team Members' Perceptions by Implementing Team Steps in an Emergency Department, this article outlines that teamwork is enhanced by communication containing the effective exchange of information. Effective communication can be arduous and challenging in high-paced, complex environments such as the emergency department, where numerous staff members are caring for patients as part of their healthcare team. Communication may be improved by structures or protocols that aid individuals in standardizing the order in which information is shared. One method for improving communication and team processes around safety is the use of the Team Steps program. This program has been used in healthcare across a variety of settings to improve teamwork. Using structured training, a work environment can be built so it may transfer new knowledge, enhancing communication and hence safety. Implementing structured communication tool can aid the team in improving the quality of their communication. This concludes my presentation. Thank you.